we go. So management of the anterior axis, as well as I'll cover the posterior axis also if the time allows. I'm talking about the softer cataracts. Soft cataract means the softest you can get is a patient who's born, and within a month, within hours, you have to operate. A patient of an ROP patient which comes with a cataract, or an ROP patient, and when you started giving intravitreal at the back. I did yesterday two patients in which the touch at the back and the cataract has to be done. These few hours old capsule versus 80 years and 90 years old capsule, I think there's a different ball game because of the collagen changes, everything, all the nature changes. Something like the egg which you put in the boiling water. When the egg is soft, it's a different protein. When it gets boiled, it's a different ball game altogether. So how do you go about? So whenever you want to manage anterior capsule rhexis in a soft cataract or an intumescent white cataract, I think you've got to be on the guard because there's a thrust from the lens which is trying to come out. Second thing, the pediatric anterior capsule behaves differently. It's more elastic. It's like it stretches, it doesn't rex that easily. And when you want to apply extra force, it will run off. So the rhexis, anterior rhexis shape of the pediatric or the soft cataract has to be important because if the shape is bigger, your lenses will come out of the bag and they'll get captured and cause more havoc. And especially in the younger age group, when the power is still changing and the lens bag changes, you're in trouble. So you have to get a 5mm rhexis. That is the standard. So how do you decide 5mm? Because what you see on the cornea is not same as what you get in the middle. So there's a magnification factor of 1.25. So you can use ultrafine on the surface, or you can use high-end microscopes like Callistos. We are blessed to have those ones, and they can project and do it. So basically, okay, now this is what you can use Utrata forceps. But the important thing here is the incisions have to be very small, and I think I'll go to the video. Now, if you see this video, that's the anterior capsule dome, and that's the posterior capsule. Anterior capsule is a convex anterior capsule, so that means the chamber has to be overfilled, so it pushes the anterior capsule down, flatter. The flatter it is, the less chance of it's running out. And on the posterior capsule is the other way around. If you overfill it, it will run off. So we'll come to that later. So what you need to do is a good viscoelastic, which fills it up properly. So here we go. All right, so you need to have a nicks on the side, make smaller nicks, and always try to stain this capsule, because when you stain the capsule, the elasticity goes down to some extent and it becomes more manageable. So I come for the side port and give a nick and just leave it. I did not go and complete it. You notice one thing, I stopped it here because my rhexis is vertical now. So I come for the main incision, and this is for the beginners I'm telling, because if they have high molecular viscoelastic, they can do it with this. Otherwise, come on, let's go. Okay, so I'm replacing the entire anterior chamber content out. I don't want a duality of the chamber. I don't want two viscoelastic. I don't want a fluid inside. Otherwise, it will run off. So you have to have a single refractive index from the middle. So replace the entire thing. So you give the nick, you come from the main port. For the beginners, you can use a Utrata forceps because you're used to using in the routine cases. But your viscoelastic has to be high, say 5 million molecular weight. So Heron, GV, everything is fine. Okay, so what you notice here is my central disc is about 5mm. I'm going around it and I'm grasping it again and again, and I'm holding it so gingerly, like I use my putter for the golf putting. And there it completes. Try not to rush it. If you try to rush the rhexis, it will always run off. Now see, that is a 5mm rhexis. The trick is to grasp it again and again, and the chamber should not lose its stability. If the chamber loses stability, your rhexis is going to run off. The important thing, most important thing here is if the chamber goes down, and if, for example, if you don't have a viscoelastic of high molecular weight, so what do you do? So then you can use a longer forceps, but your incisions will be smaller. Now I just got 2 stab incisions. My Utrata went from a 2.2 incision. Now this one is only 1.2mm incision both. You see that this bubble trapped there, that's okay. But now what I'm using is methyl cellulose and forceps, which is going from a 1.2mm opening. Now see, my forceps handle is a long handle, whereas Utrata is a short handle. It's a better control. So all the people who are doing VR surgery, they are quite used to this, but for the anterior segment, because the anterior space also is less, you have to get used to this longer forceps, right? So it's something like eating your noodles with the chopsticks versus a fork. Fork, you always can grasp it and eat it very easily like a spoon, because you've been trained for that. The Chinese might think the other way around. So you see with this also, you can get the Utrata. So in case you don't have a good heavy methyl cellulose, you can use methyl cellulose only and make side ports and just get away with that. So you see how easily I've got. Again, the trick is to hold it again and again. Try not to finish off in one go, because it's not possible, because it's so stretchy, it will always run off. Okay, so this is what I was trying to tell you. So the Rexis, for the beginners, I think it's better to use a fork or a Trata forceps and use a little heavier molecular weight OVD, but later on you can switch over to a longer forceps, and which is what we do now. So now then, once this is done, we'll go to the posterior Rexis, and then I'll finish off. So posterior Rexis, we always do a posterior Rexis in kids uh, who are more than 6 years and above. And if I have a patient who's a mentally challenged, who's got a head nodding and nystagmus, who I'm sure is not going to sit on the YAG ever, I'll do a PCC. Even the patient comes to me at 25, 30 years of age, and they're happy a lot, because when you do the YAG in the moving eye, you always pit up the lenses and cause more problem to the optics of the lens. So this is the video now which I'm showing. Now, which I showed you again, is that you see the posterior curvature is concave posteriorly. If I overfill it, one thing, the girl is going to go farther away, and second, the posterior capsule will open up the moment I give it a nick, because it's the reverse of the top of the hill phenomena. So here we go, and just see this video now. So I'm making the chamber formed, but I'm just making the chamber. I'm putting it on the iris and a very little amount in the center, so that the anterior dome actually gets pushed and becomes flatter. Do not overfill the posterior the bag. If you overfill the bag, this will always run off. So I come from the side port, again give a nick and push it off, and you see how elastic it is. And again, similarly, I'm again coming from there to the main incision now. And here I'm using always the longer forces, because the distance has gone up and there's more volume with me now, and I can control it. You see, if you don't overfill the posterior Rexis, everybody is scared of doing the capsular Rexis, posterior one, but I think that's much easier than doing the anterior capsular Rexis. For anterior capsular Rexis, if your chamber goes shallow, there's a chance of running off. Here, your capsule is, as such, as chamber is shallow. You don't want it shallow. You don't want it to be overinflated. Otherwise, posterior capsule will go further away. And you see how easily it happened. In my last 30-year careers, I had just had twice posterior Rexis running off, and my still anterior capsule runs off sometimes when there is a leak or there's a sudden surge, the anesthesia are not good, the patient is squeezing. So posterior Rexis, please do not be scared. And all the patient, even in the adults, in case you think they can't come back on the YAG, or you can't give them anesthesia again to do a capsulotomy at the back, head nodding, nystagmus, or this Parkinson patient, please open up posterior capsule central 3 millimeter. You don't have to do vitrectomy in these patients, and if you do a PCC, you'll be happier. So the grip has to be gentle. Underfilled anterior caps, the bag, the chamber can be filled, but initially we used to give a nick and put viscoelastic behind the posterior capsule, and people have started were doing that. But we realized, because there are duality of the because of the duality there of the viscoelastic, you can have it running off again. So to avoid that, you be gentle there, and do not use dye for the posterior capsule, because it will become more thinned out, and the moment you hold it fragile, it will break off. So earlier we started that whenever you used to hold it to break off, and when we were putting the implant in, the capsule used to run off. But since we stopped using the dye for the posterior capsule and underfilling the bag and properly filling the chamber, I think anybody and everybody can do this soft cataract. And I'd like to thank Dr. Harbhansdal to give me the opportunity and congratulate him on winning the election. And my time has got 7 minutes and I'm done. Please, any questions, I'm free to answer, please. Thank you.